Good afternoon, everybody. Welcome to the fourth session of the fourth PCI MENA. In this session, we'll have three speakers. The first speaker will be talking about the updates in the management of atherosclerotic cardiovascular disease, LEQVIO. Dr. Suhail Hammoudeh is a senior consultant interventional cardiologist. Dr. Suhail, please.
الناس لسه بتغدى وتحكي لهم بعد الكوليسترول بعد الغداء شوي مشكلة يعني. Okay. My talk is going to be about contemporary lipid lowering therapy. This is the main issue. And the question that I want to answer during this talk, that can we eliminate coronary atherosclerosis? Well, I guess in theory, yes. In practice, maybe كمان yes. We know that coronary artery disease, whereas CVD continue to be killer number one in the world. Each year it kills around 18 million people. COVID killed 3 million, عملنا عليها ضجة كبيرة. Coronary artery disease is killing 18 million people every year, and we are waiting something. This is just to show you that it is possible to reduce the lipid level, the LDL, by even more than 90% if you wish, and to achieve significant morphological results on the atherosclerosis. This study is experimental, done on animals with the atherosclerosis model, and they were given a combination of PCSK9 inhibitors and statin and the angiopoietin lipoprotein 3 inhibitor, which has nothing to do with the LDL receptors. It just blocks this molecule that deactivates the LPL, the lipoprotein lipase. And in this model, they were able to go down with the LDL level by 93%, and they stopped the progression of the disease, and they were able to cause significant regression of coronary atherosclerosis. Is there anything like this in humans? Yes, recently, almost 3 months back, published a study that's called Gateway Study. It's done in patients with familial hypercholesterolemia that they were homozygous, and they were given the combination of angiopoietin lipoprotein 3 inhibitor with PCSK9 inhibitor and statin therapy. And they got extra 60% reduction on the results after the first combination therapy. And now this is going to be in the phase 3 study. LDL is not a risk factor. It's not a biomarker of the disease. LDL is the cause. It is a direct cause of the disease. Why we are concentrating on the LDL? Because our target actually is not the LDL itself. Our target is the ApoB lipoprotein. And we know that the ApoB lipoprotein occurs in the form of LDL in 90% of the time, without details, because the details will take more time. How can we prove that the LDL is the disease? We have to go back to the genetic studies. If we look at the patients with, if we look at the patients on the left up, you look at the distribution of the normal LDL level in normal people, we can see that the cluster of the LDL is around 100, most of them above 100. And in people who has loss of function of the PCSK9 molecule, we can see that the distribution of LDL in most of them is below 100 and below 90. And if we compare the incidence of coronary atherosclerosis in those two groups with loss of function and without loss of function, we can see that there is 88% reduction of coronary events in patients with loss of function with much lower LDL level. So definitely it is a cause of the disease. This is an interesting study done in two different group of people. They took regular people from the MESA study in the United States with average LDL of 120, and they compared it to the Amazon people, Chimani, who lives in the Amazon in South America. In the United States, the average level of LDL was 120, and in the Amazon area, it was 75. And if you look what happened years after looking after those people, and they looked at the calcification in the coronary arteries, and we know that calcium is pathognomonic for coronary atherosclerosis. We can see all the curves going up in regular people living in United States, while actually there is no calcification in patients, in people who lived in the Amazon area, which tells you that the LDL is the cause, and there is no atherosclerosis if the LDL is at lower level. And if we look at how many of those people continue to have calcium score 0 even at age 75, in the Amazon area it is as I can see, it is 70% or more, while in the regular people, it is less than 20%. Now we know that not just the absolute magnitude of the LDL in the blood is the main issue. Now we have to understand that it is the duration of the exposure is as important as the level of the LDL in the blood. So you can see on the left side, the more LDL molecules you have, the more penetration of the LDL through the endothelium, the more plaques will have, the more plaque burden the patient will have, and the less LDL you have, and the less molecules will penetrate, and the less plaque volume or plaque burden the patient will have. And this depends upon the level and the duration of exposure. So if to put this in the curve, and to look at the cumulative LDL exposure. And how can we get the cumulative LDL exposure? It is by multiplying the LDL level by the age or the years of exposure to this level. So we can see that the patient with an average or mean LDL of 120 at certain point above 60, he will reach the threshold level, and he will continue, he will start to have actually the risk of acute coronary syndromes. And if we compare this patient to less lucky people who have familial hypercholesterolemia with mean LDL 250, we can see that the curve is shifted to the left, and they will start having the disease at much earlier age, at 30 and 40. And if we go to the patients who are more unlucky with homozygous hyperlipidemia, we can see that this group of patients will have the disease and the coronary events even at 20 at 10 and 20 years old. In comparison to more lucky people with LDL level below 180 and below, we can see that the threshold is shifted far to the right, and maybe they will live to 80 without actually coronary level. What happens in regular life, we start to see people actually, most of them, when they start to have angina, they become symptomatic, they crossed already the asymptomatic period, or they come to the ER with acute coronary syndrome at 60, 55, 60. And we start to treat them, trying to bend the curve of the risk. But what we get is very small, actually, increment. In comparison with this curve, with this patient, if we start much earlier, at 30, at 20 years old, to get the significant reduction of the LDL much earlier, we can shift the curve to the right, and we can avoid so many, actually, heart attacks. So we miss in regular life the period that we can call it now the asymptomatic plaque progression in most of those people, and we leave them without treatment because we consider that the risk of those people is low, and we start treating the consequences of the plaque burden, which is the acute coronary syndrome, and we are getting much less benefit than if we could have started this at early age. Can we calculate the risk reduction if we could have started in every patient at very young age and to get his LDL reduced by 50%? Yes, it was done by the AI, and we can see in those bars in the orange if his LDL was continuously high without any reduction, and in the blue what happens with the risk if we can get his LDL through his life to this level. So for an example, if it was 190 and we get it to 95, we'll get around 92% reduction of events. If we go to patients with less LDL, let's say 150, we can see if we convert it to numbers, we can get actually reduction from 60% to 90% risk reduction of events if we assume that we can reduce the LDL of those people by 50%, but at earlier age. So what we are doing, we start doing randomizing people late in the statin trials and PCSK9 trials at age 60, and this is what we are getting with the relative risk reduction, which is actually very minimal. So how low we can go and how safe it is go? It is safe to go to very low levels of the cholesterol, or is there a plateau of the benefit when we are going down? Are we going to see benefit at 40, at 30, at 20, or at 40 and below we are not going to see more benefit and the plateau will happen at this level? So this is taken from the UK Biobank, and we can see that by going down from the right to the left, the curve is going down and the benefit is continuous. 250 is better than 300, 200 is better than 250, 150 is definitely better than 250. But after that, we can see that the curve is getting some flattening. This happened because in the European countries, there is no much people actually with very low cholesterol or LDL level, so you cannot calculate actually the benefit. This slide is taken from the Fourier study, and we know that in Fourier study, patients were giving PCSK9 inhibitor on top of high-intensity statin therapy. And if we look at the curve, we can see that it is going down, 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 and down. And even 50 is better than 70, 40 is better than 50, and the curve is linear and continuously going down, and there is no plateau of the effect. The lower, the better, and the longer, the better, and the lowest is the best when we are going after the LDL. What did we learn from the statin trials? As you see, regardless of the baseline level of the LDL, any reduction is good. Any reduction will get you the benefit. It's not just by the statin. When we add non-statin therapy, which is the ezetimibe, to statin therapy, we are getting the same effect. And everything will happen by reducing the LDL. So we can conclude that Mother Nature doesn't care how we reduce the LDL. Any reduction of the LDL will be good. Do we have significant group of patients with LDL level below 70 that they showed the same benefit of reduction? Yes, again, from the Fourier trial, there are significant group of patients who went down below 70. So 70 is not enough, and below 70, they were included in the study at level 70, and they got significant reduction below 70, and they got significant reduction of events. Again, whatever we reduce the LDL with statins, with ezetimibe, with PCSK9 inhibitors, we are getting the same benefit regardless of that. Can we go down to 20, 21? 2,000 patients from the Fourier trial went down to the mean LDL of 21, and it was safe, nothing happened. And again, this is the linear relation between the LDL level and the benefit, and we can see it is going down, down, and down below 70, and the benefit was actually continuous. If we go to the imaging trial, same thing happened. This is GLUG trial with PCSK9 inhibitors, and we can see there is significant reduction of the plaque volume, and we know that significant reduction of plaque volume will cause significant reduction of...
You have still 1 minute.
Okay. We can look at this curve, and you see that this curve actually can give you a recommendations or guideline to what level we have to go down in every patient with LDL cholesterol. And to seize the disease at this level or to go to cause regression of the disease, definitely we have to go below 70 and we have to go below 60. So what is inclisiran? What is inclisiran, and how effective is inclisiran in reducing the LDL cholesterol? Inclisiran is siRNA, which is synthesized short molecule, and it is given subcutaneous, and we have to deliver it to the liver, and it goes by the GYNAC molecule, and it will be taken by something that's called the slicing complex, and the slicing complex will neutralize the mRNA message going from the nucleus that it is going to synthesize the PCSK molecule. So if we give PCSK siRNA the inclisiran, we'll get much less 60-70% reduction of the PCSK9, and this will get significant increase of the level of the LDL receptors that we need to take the LDL from the blood. One injection of the inclisiran was tried, 300 milligram, that causes significant reduction of the LDL level, but with some going up after that at 1 year. So when we give 3 injections at 0 time, at 90 days, and then every 6 months, we can maintain the reduction actually at 50% reduction. Is there studies done on that? Yes. The first study, the Orion 9, done on patients with familial hypercholesterolemia, and we can see that we achieved around 45 to 50% sustained reduction of the LDL. It's done in patients with ASCVD, and we get more than 50% reduction of the LDL, and it is done in a combination of patients with ASCVD and risk factors, and we get the same reduction of 50%. How many of the patients were at the target that we put when in patients who were given the inclisiran? We can raise the number from 20-30% that was done in patients in the Da Vinci study to 70-80% patients to the target, which is magnificent. What about the safety results? Actually, nothing happened. If we compare inclisiran to placebo, the only difference that we can see is the site of injection.
If you don't mind,
is the site of injection.
Conclude, please.
Conclusion, one second. Is there any data? Everybody is asking for clinical data on inclisiran. Is there, from those trials, 350 patients were done, and they looked at short period of time, actually, 18 months, and we can see that 18 months, there was 26% reduction of MACE, there was 20% reduction of fatal and fatal MI, and there was 14% reduction of fatal and non-fatal stroke. And now there is ongoing studies on inclisiran, the Orion 4, which is in 15,000 patients on a longer period of time, and the Victorian, another study going to look at what happened with the clinical events. And sorry, نتأخرت شوي.
Thank you, Dr. Suhail. Nice talk about this new subject. And let's move to the next session. We'll postpone discussion at the end of the session.
Okay, thank you, Dr. Mustafa. Next speaker will be a distinguished speaker from Jordan, Dr. Raed Awaisheh. نار على علم أو علم على نار ما أتذكرها حبيبي. He will talk about the hypertension goal and beyond the treatment of hypertension. The floor for you, Dr. Raed.
Thank you very much, Dr. Adnan, for your nice introducing me, and really I would like really to thank all the industrial companies for supporting this distinguished conference, and thank you for all of you, and your presence is really an honor for us. Thank you very much. Thank you for Boehringer for asking me to present something about hypertension, and this is one of the very important topics when you know that the worldwide most important cause of death is the cardiovascular cause of death, and it is more important in our region, more than even in the Western country. And in the Western countries, and even it is growing up with time, and still we have this problem. And when you look to the risk factors for cardiovascular disease, we find hypertension is one of the important modifiable risk factors. And we have things we cannot change, and we have things are specific to our region. So I'm trying to concentrate on some of these important points. When we come to the unmet needs not only in the diagnosis, now also the targets that we are asking by all the guidelines is going down and down, and even getting the optimal blood pressure, getting better morbidity and mortality in comparison to the normal or high normal blood pressure. So we need to control the blood pressure more and more. And when we come to the burden is huge, and this, most of this burden still in our region. In the developing country, 2/3 of this burden is in our region. And when we come to the causes of death and looking at hypertension, we find it as one of the leading causes of death worldwide, exceeding most of the other causes of causes of death. And the unfortunate thing is each patient you diagnose with hypertension, you have another one beside him you don't diagnose. So it is really a silent killer. So we have an underdiagnosis. And when we come to the treatment, 2/3 of the patients here are not controlled. So when we say it's not controlled, so just 1/3 maybe are controlled. And this will reflect directly in the cardiovascular outcome, either by the cardiovascular disease or heart disease or the cerebrovascular disease. And almost the patients who are hypertensive and not controlled, and their blood pressure is not controlled, they have almost the same morbidity and mortality, while the patients with controlled blood pressure, they have almost morbidity and mortality to patients who doesn't have hypertension relatively. And the hypertension attributed to the causes of death of ischemic heart disease, ischemic stroke, hemorrhagic stroke, other cardiovascular disease, and also for the kidney disease. So when we come to hypertension, hypertension actually can cause death by different way, either directly or indirectly. And definitely the doubling or the mortality is doubled by increasing the systolic blood pressure by 20 or the diastolic blood pressure by 10 millimeter mercury. So this is really increasing. And once you start treating the blood pressure by any medication you give, by any modifying factor, decreasing weight or whatever, any reduction of the blood pressure is very important. 2 millimeter mercury reduction will decrease the risk of ischemic heart disease by 7% and the risk of stroke by 10%. So the guidelines are recommending to treat any patient with blood pressure of less than 140 over 90 and above. And the target most of the time is less than 140 over 90, sometimes less than 130 over 80 when you have compelling risk factors and in special situations. Please always I remind myself in elderly not to take the blood pressure down too much, because you are still at the risk of falling down and getting fractures. And when we come to the patients, even if you look to this particular in this chart, if you look to the patients who have almost normal blood pressure below 140 over 90, and they have a risk factor of 10% cardiovascular risk factor, you need to give medication. So this is a very important point, even for patients who are having blood pressure less than 140 over 90, but more than 130 over 80, they need a drug actually to take the blood pressure down as per the guidelines. For the medications that we give, it is ASR, calcium channel blocker, plus minus thiazide-like diuretics, maybe thiazide-like diuretics are better. And if you still you need more to give to control the blood pressure, you go with RAS and the other medications. Not to forget the beta blocker, because we don't want to say that the blood pressure beta blocker is not there, but when you have patients with ischemic heart disease, with heart failure, with palpitation, atrial fibrillation, young women, don't forget beta blocker and keep it in your mind to use it for hypertension. The single pill medication is very important. To combine the medications in single pill is a very important issue also, to get at the end of the day, better control for the blood pressure. Any treatment, you need things in safety, effectiveness, and availability and affordability to have the medication ease access to each person in your clinic or in the community. And when we come to the blood pressure, also not to forget this point, you need to decrease the blood pressure down and to take it to the target, regardless of the medication that you will use. Any reduction, as per SPRINT trial, any reduction of the blood pressure, this will be effective. Yes, using some medications will give more effect in indirect way, but decreasing the blood pressure definitely will taking the blood pressure, and when you take it more and more down, and the tight control, when you compare it to the just achieving the target, still you are gaining benefits. Now what's happening in Jordan? In the Middle East, the prevalence of hypertension is between 40 and 50%. And when we come to the Arab countries in comparison to the Western countries, you can see that the prevalence may be less, but when you consider the age, actually, we have mean age of younger, 20 years younger. The patients or our patients are by 20 years younger. And we know that hypertension is the disease of the elderly, and we have younger population, so it is very important actually to notice this, to start the patients, screening the patients, our patients in a younger age and earlier than in the recommendations in the Western countries. This is confirmed or evidenced by also the myocardial infarction. The myocardial infarction comes in the young age in comparison to the older age in the Western countries. In the Middle East, the median age is 51 to have the first MI, while in the other countries above 60. When we come to Jordan and the meta-analysis of collections of more than one trial of 10,000 patients in Jordan and Lebanon, we can see that hypertension prevalence of 22% in our region. And when we come to the modifiable risk factors, they are there for patients with hypertension, either in men or women. And when we compare patients in Jordan to USA, for example, in USA to have one risk factor, it is in 43%, while in Jordan you have it in 23%. How about three risk factors? Three risk factors in US patients, for example, they are in 9%, while in Jordanian patients they are in 25%. So this is another thing to look for it very well and to take it seriously, that our patients, they have multiple risk factors in comparison to the others. Again, it goes with the distribution, with the prevalence, with the age, as in the Western countries. And by Dr. Al-Ajlouni, metabolic syndrome in Jordanians is really high and increasing with age. And women actually, they are having metabolic syndrome more than males, and maybe this is related to overweight and almost avoiding the activities when they get older and older. And here again, the risk factors are really for the patients, another study for the patients with PCI population. And we have, for PCI population, we have the risk factors are multiple. 30% of the patients, they have 4 risk factors and more. Women, again, they have the same problem. What we have, especially in our region, is really the sodium content in our traditional food. When you come to our food, actually we just eat salt in Jordan from breakfast till we go to bed. For example, for the breakfast and dinner, we use these foods. You know them, most of you are Arabic here, and you know most of this. This is our food. Za'atar, falafel, magdous, labani, all of these things contains lots of sodium. And you get this lunch today. Congratulations for all of you. We have overloaded you with mansaf. We overloaded you with the salt. So maybe it's good to check your blood pressure now after our food. So this is the food in our country. And when we look to the shraki bread, for example, this is our traditional food, or mashrouh bread. This is also special for almost in our region or in our country. The content of sodium is really high. That's why hypertension is a cause of death, and we rank number 8 internationally as hypertension to be a cause of death. And with time, in comparison 94 to 2004, still the hypertension is there and even increasing in prevalence. So when we come to the medications and the ARB, maybe I will concentrate a little bit on telmisartan. And telmisartan, they having the longest half-life between the ARBs and the volume distribution. And it is really an effective medication. When you increase the dose, you increase the control of the blood pressure in systolic and in diastole. And one of the advantages of telmisartan that you can give it with no need to adjust the dose according to the renal function because it is mostly excreted by the liver. So there is no need to decrease the dose when you have renal impairment. And when we come to the coverage for 24 hours in comparison to the other ARBs, for example, losartan or valsartan, it is covering the 24-hour and covering the early morning time, where you have the surge for most of the causes of stroke and myocardial infarction. So the early morning coverage is really good by giving this medication. And when we come to the efficacy for all stages of renal impairment, it's still effective even in patients on hemodialysis. So it is really a medication that you give safely, same as the other ARBs, maybe with some advantages. And when we come to the on-target trial, where it was chosen the telmisartan in comparison to ramipril as one of the best from each side, the most important point actually to tell about it, that it is maybe the only ARB did not show the difference of A's in top of R's in ischemic heart disease, and almost they have getting the same results of ramipril with an advantage of extra safety from the side effects. When we combine telmisartan to amlodipine, as the calcium channel blocker, the amlodipine, you can see that the medication is really effective and reducing the systolic blood pressure more than 50. I'm finishing before my time, inshallah. So it is really effective even in diabetic patients, in obese patients, or with metabolic syndrome. Thank you very much for listening.
Thank you very much, Dr. Raed, for your adherence for time.
Yes.
A question at the end of the sessions.
Thank you.
Thank you very much.
Our third topics in this session will be about the chlorthalidone in our medical prescription. It will be covered by our colleague, Dr. Zaher Al Kasieh. Dr. Zaher, the floor is yours. Please start.
Assalamu alaikum jami'an. I would like to thank the organizers and Hikma for inviting me to give this lecture. I'll be talking about managing hypertension with the particular interest on the combination therapy chlorthalidone and azilsartan in the management of hypertension. As you could see here, that the majority of patients, the hypertensive patients, are not reaching the goal target blood pressure lowering. You could see here, for example, in the UAE, 19% of the patients are controlled, and for example, 34% of the patients in Germany are controlled, and around 53% of the patients in the USA, they have their blood pressure controlled to down to target. Again, this is to show the effect of hypertension on the risk of cardiovascular disease, starting at a blood pressure of 115/75 millimeter mercury. The risk of death from ischemic heart disease and stroke doubles for every 20 millimeter mercury increase in systolic blood pressure, or a 10 millimeter mercury increase in diastolic blood pressure. So you can see here the risk increasing from 2 times risk to 4 times risk to 8 times risk as the blood pressure goes from 115/75 to 175/105. So in fact, reducing blood pressure and reaching target is of paramount importance. Now, to show here the population effect of blood pressure reduction on mortality in an analysis of 5 major observational studies, it demonstrated that small differences in systolic blood pressure would result in significant risk difference in developing complications. Reduction of systolic blood pressure by 5 millimeter mercury is expected to reduce stroke mortality by around 14% and reducing cardiovascular heart disease mortality by around 9% and reducing all-cause mortality by around 7%. And in a meta-analysis of 61 prospective randomized studies involving 12.7 million person years demonstrated that modest 2 millimeter mercury reduction in systolic blood pressure was associated with reduction in stroke mortality by 10% and reducing ischemic heart disease mortality by 7%. And looking here at the modifiable risk factors in the global mortality, you could see that hypertension is on the top of the list, both in developing regions and developed regions, followed by tobacco and high cholesterol. And to show here the number of medications that are needed to achieve the goal systolic blood pressure, looking at patients without chronic kidney disease and patients with chronic kidney disease. Those without chronic kidney disease, you would need between 2 to 3 medications and sometimes more to control blood pressure out of the HOT trial, UKPDS, ALLHAT, and INVEST. And those patients with chronic kidney disease, out of multiple trials, including the renal, you could see that you would need up to 4 medications in order to control blood pressure. Now, hypertension is a common risk factor in both cardiovascular disease and chronic kidney disease. It is often poorly controlled, especially in patients with advanced chronic kidney disease. And thiazide or thiazide-like diuretics like chlorthalidone are important agents for lowering blood pressure in patients with essential hypertension. Chlorthalidone, which is a thiazide-like diuretic, reduces cardiovascular morbidity, such as the incidence of stroke and heart failure, and it reduces cardiovascular mortality. However, its efficacy and safety among patients with advanced kidney disease remains poorly understood. Now, this is to show the nephron structure with the glomerulus, the proximal convoluted tubule, the loop of Henle, and the distal convoluted tubule, followed by the collecting duct. And this is to show the site of action of the different diuretics. Mannitol and acetylzolamide, they work on the proximal convoluted tubule, where 60 to 80% of the sodium would be reabsorbed. And furosemide and torsemide, they act on the ascending limb of the loop of Henle, while in the distal convoluted tubule, you have the action of hydrochlorothiazide, chlorthalidone, and indapamide. And also, in the distal part, you have amiloride, triamterene, and spironolactone. Now, hydrochlorothiazide, which is the prototype of thiazides, and also other thiazides, also chlorthalidone, metolazone, and indapamide, they are all sulfonamide derivatives with a half-life between 6 to 12 hours. The mechanism of action, the thiazides are secreted by the proximal tubules, but they work in the distal convoluted tubule. They inhibit sodium chloride symporter from the lumen to tubular cells, and this leads to increase in sodium and chloride excretion with water. And some of the thiazides, they do have some weak calcium antagonistic effect. Now, sodium and water regulation by the nephron, looking at distal convoluted tubule, the urine flows into the distal convoluted tubule, where 5% of the sodium would be reabsorbed by the sodium chloride co-transporter. The thiazide diuretics, they inhibit this co-transporter. And the molecular mechanism of action is the block of the sodium chloride co-transport in the distal tubule for diuresis. Also, there's opening of the calcium-dependent potassium channel in vascular smooth muscle, reduction in sodium in vascular smooth muscle, reduction of sodium contribution to arterial and cardiac remodeling, with some effect of the enhancement of nitric oxide production by endothelial cells, now eventually leading to a significant reduction in blood pressure. The physiologic mechanism is a transient decrease in extracellular fluid volume followed by a small sustained decrease with no lasting change in cardiac output, but there is a sustained reduction in peripheral resistance. Now, to show the potency of the different thiazide diuretics, it is 0.1 for chlorothiazide potency with a half-life of 2 hours. For hydrochlorothiazide, the potency is 1 with a half-life of 3 hours, while looking at chlorthalidone, the potency is 10 with a half-life of 6 hours. Now, could chlorthalidone be the first choice out of the diuretics? Large trials using chlorthalidone, including OLHAT and CHIP, have demonstrated reductions in cardiovascular endpoints, with the evidence for hydrochlorothiazide is less robust. And a network meta-analysis of 5 trials comparing different diuretics, it showed that only endopamide shared the same potential for improving clinical outcomes as chlorthalidone. So you have to consider chlorthalidone when initiating thiazide diuretics for hypertension, and you would prescribe 2.5 milligram of chlorthalidone daily initially, and then you could increase to 25 milligram afterwards. And higher doses would tend to cause more side effects, including hypokalemia, but minimal further blood pressure reduction. You have to be cautious in looking at potassium and magnesium in the follow-up of these patients. Now, thiazide diuretics are considered to be first-line therapy for hypertensive patients without compelling indications for alternate drugs. And the advantage of thiazides is the availability in many combination therapies which can improve adherence. Now, the side effects you have to look at, you have to monitor potassium, chloride, magnesium, and calcium. Now, to look here at the hydrochlorothiazide as compared to chlorthalidone, you could see that the half-life is 6 to 9 hours for the thiazide, while it is up to 40 hours for chlorthalidone, and there is 1 to 3 orders of magnitude stronger on the chloranhydrase isoenzyme inhibition. And you can see here that comparing chlorthalidone to hydrochlorothiazide, the relative carbonic anhydrase inhibition is +1 to hydrochlorothiazide, while it is +3 for chlorthalidone. And the elimination half-life is 9 to 10 hours for HTZ, while it is 50 to 60 hours for chlorthalidone. Now, looking here at the equivalent dosing between hydrochlorothiazide and chlorthalidone, you could see that milligram for milligram chlorthalidone is more potent than hydrochlorothiazide in lowering systolic blood pressure and mean blood pressure lowering. Now, this is to show the position papers of the national guidelines regarding the choice of diuretic. The AHA scientific statement on resistant hypertension says that given the outcome benefit demonstrated with chlorthalidone and its superior efficacy compared with hydrochlorothiazide, chlorthalidone should be preferentially used. And the ASH position paper on the treatment of hypertension in patients with diabetes again says that chlorthalidone is the suggested thiazide diuretic, since this is the diuretic used in clinical trials and it forms the basis for the cardiovascular outcome data. And the ISHIB consensus statement says that chlorthalidone differs from hydrochlorothiazide in that it has a much longer half-life and has been shown to more efficiently decrease blood pressure. And we favor the use of chlorthalidone over hydrochlorothiazide in most situations. And also the NICE British guidelines on the management of primary hypertension in adults, it says that it should offer a thiazide-like diuretic such as chlorthalidone in preference to a conventional thiazide diuretic such as HTZ. Now, this is to show the effect of chlorthalidone on cardiovascular outcomes in the landmark trials. Out of the HDFP trial, you could see that there was a significant reduction in cardiovascular mortality by 17% as compared to usual care. The Mr. Fit showed that the chlorthalidone reduced mortality as compared to hydrochlorothiazide, and that it lowers the risk of cardiovascular events by 21% as compared to hydrochlorothiazide. And the SHIP trial showed also lowering of the risk for cardiovascular disease by 32% as compared to placebo. The same also with the old hat, with the superiority over amlodipine and lisinopril in the prevention of cardiovascular disease, and it is the recommended thiazide type diuretic for the first-line treatment of hypertension. So in conclusion, concerning diuretics are the only class of drugs that directly deals with the fundamental cause of hypertension, that is sodium retention, and it is considered first-line therapy for most forms of hypertension as a standard of care, and it is inexpensive, and it has a long-standing history of use with efficacy and tolerance, and it is often necessary to use diuretics, the thiazide diuretics, in combination therapy with other antihypertensive that may cause salt and water retention as a compensatory response. Now, looking here at the combination therapy of azilsartan, midoxamil, and chlorthalidone in IDARBI chlor, you could see here that the rate of dissociation of ARBs, a comparative rate of dissociation from AT1 receptor, you could see that the inhibition of AT1 receptor is highest for azilsartan. Now, looking here at the combination therapy of azilsartan with chlorthalidone in a factorial study, you could see here they compared chlorthalidone monotherapy 12.5, 25 milligram, and azilsartan monotherapy 20, 40, and 80 milligram with a combination therapy of azilsartan and 12.5 milligram chlorthalidone, and also azilsartan 20 milligram with 12.5, 80 milligram with 12.5, then again, 20, 40, and 80 azilsartan with 25 milligram combination therapy with chlorthalidone. And this is to show the change from baseline, change in systolic blood pressure, in the mean change in systolic blood pressure from baseline by ambulatory blood pressure recording. You could see that whether you look at the systolic blood pressure or diastolic blood pressure, you could see that there is an additive response when you compare monotherapy with chlorthalidone to combination therapy with 20 milligram of azilsartan with 12.5 and 25 milligram dose of chlorthalidone, and the increased response when you combine with 40 milligram and 80 milligram of azilsartan, and again increasing doses of chlorthalidone. There's a significant reduction in both systolic and diastolic blood pressure as compared to monotherapy with chlorthalidone. And this is to show those patients who are reaching their guidelines of the goal pressure attainment at 8 weeks. You could see that up to 85.4% of the patients on combination therapy of 80 milligram azilsartan and 25 milligram of chlorthalidone achieved the goal blood pressure. And with a combination of 40 milligram and 25 milligram of chlorthalidone, 81.3% they achieved the guideline. So actually, there's not much significant difference between 40 milligram and 80 milligram dose of azilsartan, and probably this is the working horse of azilsartan as combined with chlorthalidone.
1 minute.
And this is to show the probability of achieving the systolic blood pressure. Again, it is maximal for azilsartan chlorthalidone 40-25 milligram combination. And looking at those patients with baseline blood pressure up to 190, you have 190, 180, and you could see that the response is highest for this combination as compared with monotherapy of azilsartan 80 milligram and chlorthalidone monotherapy. Now, concerning the looking at serum potassium, if you use only chlorthalidone, there is some reduction in potassium. If you combine that with azilsartan, then the hypokalemic response would be attenuated looking at with increasing doses of azilsartan. Now, looking here at a combination, comparative response of combining azilsartan with hydrochlorothiazide to a combination of azilsartan with chlorthalidone to see the difference in response at increasing doses. And this is to show that there is a significantly more reduction in systolic and diastolic blood pressure at week 6 and week 10 with a combination therapy of azilsartan and chlorthalidone as compared to azilsartan and hydrochlorothiazide. And to show that the difference between the fixed dose combination azilsartan chlorthalidone compared with other combinations, this is the difference in favor of azilsartan chlorthalidone. You could see that up to 14.6 milligram difference with other ARBs combined with hydrochlorothiazide. So in summary, in conclusion, a total of over 4,000 patients were evaluated for safety when treated with a monotherapy with azilsartan, and it showed that adverse reactions were generally mild, not dose dependent, and similar regardless of race, gender, or age. And the overall incidence of adverse reactions with monotherapy were similar to placebo. The most common adverse reaction was diarrhea, up to 2% of 80 milligram monotherapy azilsartan as compared to 0.5 milligram with placebo monotherapy. And withdrawal rates due to adverse reactions were low, 2.2% with azilsartan 40 milligram, 2.7% with 80 milligram, 2.4% with placebo. And the most common adverse event leading to discontinuation was hypotension, orthostatic hypotension. And the final slide, over 3,900 patients were evaluated for safety with combination therapy with chlorthalidone, more than 700 patients treated at least 6 months, and 280 patients were treated for at least 1 year. The adverse events were generally mild and transient in nature. The most common adverse events were dizziness, 8.9%, and fatigue, 2.0%. And withdrawal rates due to adverse events occurred in 8.3% of patients treated with the combination, 3.2% for the monotherapy of azilsartan monotherapy and chlorthalidone monotherapy. The most common reason for withdrawal of therapy were serum creatinine increase, 3.6%, and dizziness, 2.3%. So the adverse events and discontinuation due to adverse events were less frequent in the 3 double-blind titration studies. When you titrate the dose of azilsartan and chlorthalidone, it was the adverse events were lower than if you use it suddenly. Thank you very much.
Thank you, Dr. Zaher, for this nice talk, and we have time now for to open the floor for discussion and comments. And if you allow me, I would like to make a comment on Dr. Suhail lecture, where he showed us a very attractive slide, where he compared where in the slide there was comparison between Amazonian community with the city community by LDL 75 to 125, and how on long run the coroners were clean of calcium at 80s and even more. I think we induce the disease, and at the end we look for a drug for that disease. People around the world are talking about civilization diseases. Nowadays, diabetes, coronary artery disease, hypertension, obesity, high LDL is considered as a civilization disease. 10,000 years ago, agriculture revolution started, and 200 years ago, the industrial revolution started, and as a result, pure sugars, flour, and oils are made available on every table in a city. Easy accessibility to these elements of nutrition that caused obesity, hypertension, coronary artery disease, strokes. In those Amazonian primitive communities where they do a lot of effort every day in hunting to obtain their food. They do a lot of exercise. They don't have available pure sugar, flour. They don't have obesity. Barely you find somebody who gets myocardial infarction, hypertension. In these communities, we don't find this. It's not matter of genetics. It's matter of civilization. And we have, I'm not calling to go back to hunting and to live as those people in villages, but we have to stress on healthy lifestyle. We have to go back to exercise and healthy food.
Dr. Mustafa بيحكي صح إنه if we ask the question what is the normal level, there is no definition. In my opinion, all the guidelines are misleading. all the هدول التيبلز هاي ما لهاش علاقه بنوفارتس او بحدا انه very high risk, low high risk, moderate risk مش عارف شو 70 انه there should be normal level. Everybody is considering the normal level of blood pressure is 130/80 and nobody will accept blood pressure 150 and the rest of blood pressure above 90. It should go down. There is no definite definition of what's the normal LDL level that should be in normal human being. And it is calculated, it's 25. 25 is enough for the normal physiological function of the cholesterol in the body, for hormone making, for testosterone making, for everything. 25 is enough because it is calculated if you, what's the concentration of the LDL that should be in the interstitial tissue. Before it goes to the receptor, it is 2.5. And if you multiply that by 10, it is 25. So 25 milligram percent is more than enough in the blood to keep the normal physiology of the cholesterol. So maybe it is the normal level. And anything above that is bad. The same thing that in that slide, we need not just to lower the cholesterol, we need to affect the disease, to stop the progression and to cause some regression. At a certain point, the reduction of the events will be magnificent. And with that, we have to go down and down. And now we know statins are not enough. And the other misleading point, in my opinion, it is high intensity statin therapy, moderate intensity statin therapy, mild intensity statin therapy. Now we know any initiating dose of statin gives us 90% of the effect of the statin. And by doubling the dose, another 6% of the 30 is nothing. It will not add, it will not be enough. And now we have to go immediately with combination therapy, with non-statin to statin, and maybe in 50% of the patients, this will not be enough, and we have to add PCSK9 inhibitors, or inclisiran, SRIA, and more compounds to come on.
Thank you.
I have a question to Dr. Raed Awaisheh. Actually, we face a lot of patients with heart failure and mid-range ejection fraction, and heart failure, or even heart failure with preserved ejection fraction, and they are on telmisartan, olmesartan, valsartan, and so on. In your daily practice, do you prefer to change them to ARNIs, or you prefer to keep them on same treatment if they are they get improvement, or you should follow the guideline?
Your question is about my patients. My patients, actually, I give them what they can afford. This is the most important thing. What they can afford, I give to them. I mean, if they cannot afford ARNI, so we'll give ACE or ARB, whatever they can afford. Because the most important thing is these 4 pillars actually to be given to heart failure, even for the, maybe it is for reduced ejection fraction, it is more confirmed, but even for the mid-range, we treat them almost as a reduced ejection fraction. But in preserved ejection fraction, the only proved thing is the, as you know, maybe recently by the
class 2B, class 2B.
Yeah, maybe now it is just the SGLT2 inhibitors, the only things to be given in preserved ejection fraction. But which you give is or ARB or ARNI medication, I think by the guidelines till now no one of them has been proved, and what they can, my patients, what they can afford, I give them.
Thank you.
Yes, doctor. Yes, there.
I just want my good friend Dr. Suhail to comment on what I'm going to read. Despite the causative role of the LDL in the development of atherosclerosis, significant proportion of patients with high LDL have neither evidence of atherosclerosis nor development of atherosclerotic vascular disease at long-term follow-up. In one study, 46% of patients with LDL more than 190 milligram per DL had calcium score of 0.
Very excellent question, Ayman. The continuity of your question في slide بيجيبوا الناس اللي who need an argument against LDL reduction and against the lipid, the LDL is the cause of the disease. And if you remember two curves, and there is interaction between them, and they will tell you that most of the people with coronary artery disease, they have the average level of LDL. Now we know when we started treating people, we went from the high level, it is 140, 150. We are talking about the early 90s. And we went down to the average level. The average level had all the patients who were then enrolled in the heart protection study. And we understood from that study that going lower to 90 is good. And then the TNT, high intensity versus low intensity. And we got to lower level and we got more effect. And then with the PCSK9 and then adding non-statin to statin, going down and down. How can we explain that slide? Because genetically, not all the people are the same. If I have serum level of LDL of 90 and you have 90, you might not have the disease. I might be full of plaques because the 90 has not the same effect on the same individual, on different individuals with the same duration of exposure. It has different effect. This is why we need to go down and down and down. But it looks that when you go 70 and below, it will be good for everybody. It will give you the reduction that you need. But it doesn't mean if somebody living with LDL of 90 and he doesn't have the disease, that it is an argument against the LDL theory as a cause of the disease.
Thank you, Dr. Suhail. Clear. Dr. Abdullah.
My question to Dr. Suhail. I think the lowest number of LDL which is recommended by guidelines was 40 for those with high. It was not 25 because, as you said, it's very essential for brain function and for
Abdullah, and I'm not recommending the level 25.
دكتور عبد الله خليني احكم بيناتكم. في واحد اسمه اوكيفي and اتقال calculated the lowest risk, يعني الريسك بصير زيرو بس يوصل LDL ل 30.
Yes, but my question is something else now. We've been waiting for the small interfering RNA PCSK inhibitors for a long time, but from my own experience, the main concern is price with regard to this, because the other brands which are available, they cost like 10,000 per year. This is
the monoclonal antibodies. The monoclonal antibodies بدهم more than 6,000 per year. والانكليسيران priced by Novartis على 2000 في السنة. 2000 في السنة على فكرة لو تحسبها للمريض it is 160 GD per month. It's not that يعني it is expensive بس مش catastrophe.
So it will be price-wise, it will be a game changer, I think.
Yeah, it is.
Because the main issue.
الميكروفون دكتور عبد الله الميكروفون.
The main issue with the older, brands was the price because they were not affordable.
Yeah, if you look, هو كمان they are كمان issues. يعني هو it's totally different from the monoclonal antibodies. What's the penetration of evolocumab or Repatha? مش بس في الأردن في العالم كله. It is 3-4-5%. It is because of the price. It is because the adherence is very difficult. You need an injection every 2 weeks.
Every 2 weeks, yeah.
Every 2 weeks injection يعني هيك شوي بجوز تبلش
it is more
المرضى
convenient.
price plus that and you will keep the swinging curve of the LDL up and down. But with inclisiran, it is one injection every 6 months. The adherence is much.
Okay, thank you. More questions? Okay, this is the end of this session. Thank you,
دكتور ياسر،
everybody.
كان عنده سؤال.